Today, Professor Dr. 𝗬𝗶, a senior consultant neurologist from University of Medicine 2, will present a topic on motor neuron disease diagnostic pitfall.
Good afternoon, everyone. Thank you, Mama Professor 𝗬𝗶 for kind introduction. I'm Professor 𝗬𝗶, Senior Consultant Neurologist. In today's Neuromuscular Symposium, my topic will be motor neuron disease and its diagnostic pitfall. These are the outline of my presentation. The first part will be overview of motor neuron disease, and the second part will be diagnosis, and the last part will be the case presentation. Now let me start overview of motor neuron disease. Motor neuron disease, also known as amyotrophic lateral sclerosis or Lou Gehrig disease. It is a heterogeneous neurodegenerative disease characterized by degeneration of upper and lower motor neurons, leading to motor and non-motor symptoms. Diagnosis is mainly clinical, but treatable mimic must be excluded before the diagnosis is ascribed. It has invariable fatal outcome. Mortality is usually from respiratory failure. Management, therefore, focus on the symptom relief and preservation of independency and quality of life. Regarding epidemiology, motor neuron disease is relatively uncommon, with annual incidence 2 in 1 million and prevalence of 5 per 1 million. But the incidence is lower in the South and East Asian country, approximately 1 in 1 million population. The incident peak is in the age of 50 to 70 years. Young onset MND has a slower progression and usually occur under the age of 45 years. And juvenile onset MND is very rare and family history is usually present. Male are more common than female. There are 3 different types of motor neuron disease: amyotrophic lateral sclerosis, progressive muscular atrophy, and primary lateral sclerosis. ALS represent 85% of all MND cases, with the features combine upper and lower motor neuron dysfunction. PMA account for 5% of MND, and it present with lower motor neuron dysfunction with flaccid weakness and muscle atrophy. PLS account for 2 to 3% of MNL, present with upper motor neuron dysfunction with substantial muscle spasticity. Among them, ALS is the most severe form with rapid clinical decline. The survival usually is 3 to 4 years from the symptom onset, but PMA and PLS associated with longer survival. And this picture clearly describes the types and subtypes of motor neuron disease. As I mentioned previously, there are 3 different types: PMA, ALS, and the PLS. ALS is further subdivided into the Flynn variant, limb onset variant, and the Barber onset variant. In addition to the pure motor involvement, there is behavioral, cognitive, and multi-system dysfunction. Regarding phenotypic presentation of ALS, the presentation is very variable. It has motor feature as well as cognitive features. The motor features are further subdivided by the regional onset, like Barber onset ALS and the spinal onset ALS. And again, it can be subdivided by upper motor neuron or lower motor neuron involvement, like PLS or PMA. So I will present with the spinal onset ALS. It accounts for 65% of all ALS cases. The presentation will be asymmetric, painless weakness and atrophy occurring in the dominant limbs, and then spread to the contralateral limb. Median survival of the spinal onset ALS is approximately 3 to 5 years. Barber onset ALS account for 25%, which is also known as progressive 𝗑𝗶𝘴. Dysarthria is the first manifestation of Barber onset ALS. Dysphagia, dense fasciculation, and pseudo-Barber effect are very common and the prominent sign in the Barber onset ALS as well. It is more common in women and elderly, and the worst prognosis with approximate survival of 2 years. The respiratory onset ALS account for 5% of the ALS patients, characterized by atopia and dyspnea without spinal or 𝗑𝗶 sign. The diagnosis is very challenging, and the prognosis is very, very poor, with median survival of 1.4 years. The XCF variant ALS is very rare, and the disease started in the paravertebral muscle with two posture as the presenting symptom. Males are predominantly seen. Then I will present further about the presentation of ALS based on the upper motor neuron or lower motor neuron involvement. Before going into the further slides, let me refresh your memory. What are the upper motor neuron signs and lower motor neuron signs? Upper motor neuron signs include 𝗵𝗶𝗴 sign, hyperreflexia, spasticity, 𝗬𝗶𝗴 effect, exaggerated jaw jerk, and Hoffman sign. Lower motor neuron signs are atrophy, weakness, fasciculation, hypo, or areflexia. Progressive muscular atrophy type of ALS is the lower motor neuron predominant type. The patient presents with typical lower motor neuron symptoms of progressive flaccid paralysis. Symptoms are usually asymmetric and started in the distal limbs. The progressive worsening of lower motor neuron signs and appearance of upper motor neuron signs in 20 to 30% of cases within 5 to 10 years. It has a better prognosis and slower rate of progression. Another type is Flynn syndrome, also known as scapulohumeral form of ALS, Hankin-Am syndrome, neurogenic man in a barrel syndrome, and brachial amyotrophic diplegia. It is characterized by progressive predominant lower motor neuron pattern of weakness in the upper limb, mostly symmetrical, and typically begin in the proximal muscle and progress to the distal involvement. 𝗑𝗶 symptoms occur in 77% and high male preponderance. Prognosis is better than that of classical ALS, with median survival of 4 years. The Flynn syndrome, also known as pseudopolyneuritic or peroneal form of ALS. It is characterized by progressive asymmetrical lower motor neuron pattern weakness with distal onset weakness. Progression is slightly slower compared to classic ALS. Rawbest syndrome is another lower motor neuron predominant types of ALS. It needs to be differentiated from myasthenia gravis or myopathy. Primary lateral sclerosis is the upper motor neuron predominant type of ALS. It accounts for 3 to 5% of the all ALS cases. It is characterized by progressive spasticity and slowing of movement. It has a slower progression. Median survival is 20 years, but it can evolve into ALS typically within 3 to 4 years after disease onset. Another rare form is hemiplegic variant, so-called Mills syndrome or progressive hemiplegia. Usually begin with unilateral upper motor neuron involvement in the lower limb, followed by slowly progressive ipsilateral involvement of the arm with relative sparing of the face. After a period of time, the disease spread to the unaffected site. In addition to the motor features, there are non-motor involvement in ALS. Up to half of ALS patients develop some cognitive involvement. Sometimes cognitive problems usually precede that of motor dysfunction. The commonest symptoms are executive dysfunction and apathy. 25% of patients with ALS meet all the criteria for frontotemporal dementia, mostly behavioral variant. There are many conditions that can mimic motor neuron disease, especially in the lower motor neuron type. These are benign fasciculation, multifocal motor neuropathy with conduction block, motor predominant CITP, neuralgic amyotrophy, Kanedi, Hirayama inclusion body myositis. These conditions need to be excluded before diagnosis of motor neuron disease is established. In the upper motor neuron variant, hereditary spastic paraparesis and primary progressive multiple sclerosis need to be excluded. In the mixed form of the motor neuron disease, cervical myelopathy, syringomyelia are the main differential. So I will move on the second part of my presentation, which is diagnosis of motor neuron disease. Diagnosis is mainly based on the clinical finding with support of electrophysiology, imaging, and laboratory technique to exclude other diseases. So when will you suspect motor neuron disease? There are important diagnostic pointers in primary care. One is asymmetrical distal weakness, brisk reflexes in wasted hand or limb, absence major sensory symptoms like pain and bladder dysfunction, slurring of speech accompanied by obvious wasting and fasciculation of tongue. And the last one, but very important, is relentless progression of symptoms and signs during follow-up period. So how to diagnose motor neuron disease? Motor neuron disease is diagnosed based on the history, examination, and the investigation. The important history and the key features are painless progressive asymmetric weakness, which is initially localized, sometimes limbs, sometimes bulbar, and some cases with early behavioral changes, with absence of sensory symptom. These are the key features in the history. In the examination, the key characteristic findings include the presence and upper motor neuron and lower motor neuron signs, muscle wasting, and split hand sign. Split hand sign has 95% specificity to diagnose motor neuron disease. And widespread fasciculation and non-motor findings like apathy, disinhibition, and emotional lability are also another important findings in clinical examination. The investigations include blood tests, neuroimaging, and the neurophysiology. There are many signs with high predictive value for the motor neuron disease where there is a history of progressive motor-only weakness. The first one is generalized fasciculation, which can be easily missed over the anterior shoulder. The second is bilateral wasting of tongue, especially at the lateral borders, particularly associated with fasciculation and brisk jaw jerk or orbicularis oris reflexes. Tongue wasting and fasciculation is also another high predictive signs of motor neuron disease. At the split hand sign, specificity of 95% to diagnose motor neuron disease. That means the preferential wasting of lateral border of the hand. As shown in the figure, the head drop is also another features of the motor neuron disease with high predictive value. In the patient with head drop, myasthenia gravis need to be excluded. Emotional lability, like crying, especially with bulbar weakness, and abnormal response to 𝗬𝗶𝘀 is another important features. And cognitive and behavioral impairment like frontotemporal dementia is also a high predictive value for the motor neuron disease. So because of the incurable nature of the motor neuron disease, diagnostic certainty is very important before the diagnosis is established. That's why there are many diagnostic criteria for the ALS or MND. Up to 2000, we use 𝗬𝗏 criteria to diagnose motor neuron disease. But this criteria is very complicated, so at the 2020, changed to the 𝗂𝗂𝗃 criteria, which is simplest form of diagnostic criteria, and it includes 3 facts. Number 1 is documented history of progressive motor impairment after a period of normal motor function. Number 2 is presence of both upper and lower motor neuron signs, at least one body region, or lower motor neuron dysfunction in at least 2 body regions. Number 3 is very important one, is thorough investigation must be excluded to rule out any other possible disease process. So the sensitivity of 𝗂𝗂𝗃 criteria is 90% for the diagnosing ALS. These are the EMG changes in the motor neuron disease. Actually, EMG is needed for the evidence of lower motor neuron dysfunction. Signs of active denervation like fibrillation, positive sharp wave, or chronic denervation like large MUAP and fasciculation potential are the common features seen in the patient with motor neuron disease. But Absence of these features does not rule out the diagnosis, and these features considered helpful in the diagnosis of ALS. So this is my final part of the presentation, the case study. The case 1. 58 years old male, 2-month history of left lower limb limping, difficulty in climbing steps, and left foot weakness. After 1 month, he noticed the weakness spreading to the right side. He was unable to stand from sitting without using his arm for support, nor able to walk unassisted. After 3 months, he noticed difficult using left hand, loss of strength, and began traveling day-to-day activities. He also noted muscle twitching occasionally in thigh and arms. He subsequently noticed slurring of speech, but there was no swallowing difficulty nor shortness of breath. He has no sensory symptom nor sphincter dysfunction, no known past medical history, apparently normal before the onset of his symptoms. Neurological examination show normal high mental function, normal sensory cranial and cerebellar examination. The picture A မှာပြထားတာကတော့ split hand sign ကိုပြထားတာပါ preferential wasting of the lateral border of the hand မှာ the picture B မှာကျတော့ hand wasting and fasciculation တွေကိုပြထားပါတယ် C မှာပြထားတာကတော့ fasciculation florid fasciculation တွေ thighs တွေ arms တွေမှာရှိတာကိုပြထားတာပါဒါကြောင့်မလို့ဒီ patient မှာ predictive value တွေရမ်းများတဲ့ split sign fasciculation ဒါတွေကိုတွေ့နေရပါတယ် motor examination မှာတော့ distal weakness က prominent ဖြစ်တယ် left side သည် more weakness than the right side examination မှာ reflex တွေက exaggerated ဖြစ်နေတယ် jaw ချက်သည် breaks ဖြစ်နေတယ်ဒါကြောင့်မလို့ဒီ patient သည် missed lower motor neuron and upper motor neuron ရောနေတဲ့ ALS ဖြစ်နိုင်တယ်သို့ပေမဲ့လည်းကျမတို့ရဲ့ diagnostic criteria အရ other treatable cause တွေကို exclude လုပ်ရမှာဖြစ်တဲ့အတွက်ကြောင့်မလို့ cervical myeloradiculopathy တို့ 𝗬𝗶𝗴တို့ 𝗬𝗶𝗴တို့ exclude လုပ်ရပါမယ်ဒါကြောင့်မလို့ investigation တွေကို proceed လုပ်တယ် MRI brain နဲ့ cervical spine လုပ်တော့ unremarkable nerve conduction study normal EMG မှာတော့ active denervation ရော chronic reinnervation changes တွေကဘာဘာ cervical thoracic နဲ့ lumbosacral segment တွေပါအများကြီးတွေ့ရပါတယ်ဒါကြောင့်မလို့ LS Korea GOCOS criteria အရာ EMG criteria အရာတော့ more than 2 region မှာ denervation changes တွေကိုတွေ့နေရပါတယ် summarize ပြန်လုပ်မယ်ဆိုရင်ဒီ patient သည် pure motor distal asymmetric weakness and wasting of hands and feet progressive rapidly in 6 months clinically မှာ presence of upper and lower motor neuron sign ဟာ clinically မှာလည်းပါတယ် EMG changes မှာလည်းပါတယ် 4 region မှာပါနေပါတယ် now other diagnosis တွေကိုလည်း appropriate investigation နဲ့ exclude လုပ်ထားပါတယ်ဒါကြောင့်မလို့ဒီ patient ရဲ့ final diagnosis ဒီ classical spinal onset ALS ဖြစ်ပါတယ် case number 2 50 years old man present with difficult lifting arms for 3 months followed by difficult standing from squatting There was no symptoms of tingling and numbness apart from aching pain in the thigh. Weakness progressed over 1 year and he encountered difficulty using his hand and problem doing daily activities. Then he needs assistance in walking for long distance. No swallowing problem or no slurring of speech, no problem with bladder and bowel dysfunction. He has no previous medical illnesses. No chronic exposure to fertilizer nor insecticide. Neurological examination ma marked wasting in the proximal muscle of upper limb. Arms, the shoulders, the area wasting ne mark ဖြစ်ပါတယ် tan fasciculation နဲ့ tan wasting နဲ့မရှိပါဘူး motor power ကတော့ proximal symmetrical proximal weakness upper limb တွေမှာ shoulder တွေမှာ motor power 1ပဲရတယ် elbow မှာတော့ 2 lower limb မှာလည်းအဲ့လိုပဲ hip မှာ motor power 3 all the reflexes are absent plantar response ကတော့ flexor ပဲရပါတယ်ဒီ video မှာ နံပါတ် A မှာပြထားတာကတော့ fasciculation နဲ့ fasciculation တွေကို back မှာတွေ့ရတယ် shoulder တွေမှာတွေ့ရတယ် video B မှာပြထားတာတော့ areflexia ကိုပြထားတာပါ video C မှာတော့လမ်းလျှောက်တဲ့အချိန်မှာ hanging arm လက်နှစ်ဖက်စလုံးရဲ့ proximal weakness ရနေတဲ့အခါကျတော့ hanging arm pattern နဲ့လမ်းလျှောက်နေတာကိုပြထားတာပါ ဒါကြောင့်မလို့ motor neuron disease လို့ diagnosis မတက်ခင်မှာကျမတို့ဒီ differential lower motor neuron variant ရဲ့ differential တွေကိုစဉ်းစားရပါတယ်။အဲ့ဒီမှာ motor neuropathy with conduction block တွေ peripheral nerve ပြဿနာတွေ myopathy တွေ other rare form တွေဖြစ်တဲ့ condition တွေကို exclude လုပ်ရမှာဖြစ်ပါတယ်။ဒါကြောင့်မလို့ laboratory investigation အနေနဲ့ masses creatinine kinase ကိုဖောက်လိုက်ပါတယ် to exclude myositis CK က normal ပဲ MRI cervical spine လုပ်တယ် reticulopathy ကို exclude လုပ်ဖို့အတွက်ပါအဲ့ဒါမှာတော့ OA changes လေးပဲရှိတယ် root compression တွေမရှိဘူး nerve conduction study က peripheral neuropathy multifocal motor neuropathy with conduction block တွေကို exclude လုပ်ဖို့အတွက်လုပ်လိုက်တယ် normal ပါ EMG မှာတော့ widespread active denervation and chronic renervation တွေက cervical နဲ့ lumbar region မှာတွေ့ပါတယ် two region မှာ EMG changes တွေကိုတွေ့ရပါတယ် summarize ပြန်လုပ်မယ်ဆိုရင်တော့ဒီ patient ဒီ slowly progressive symmetrical motor weakness in proximal muscle of upper limb followed by distal weakness sensory examination က normal ပဲ nerve connection study မှာလည်း sensory က normal ပဲ EMG မှာတော့ presence of lower motor neuron sign in the two regions and exclusion of other diagnosis by the blood test and neuroimaging နောက်ဆုံးဒီ diagnosis ဒီ Hlaem syndrome which is lower motor neuron variant of ALS let's move to the case 3 so a 22-year-old man came with history of incident onset of weakness in both hands for 4 years duration weakness started in the right hand muscle which was gradually progressed to the forearm within 6 months he did not have any pain loss of sensation diplopia dysphagia ptosis muscle cramp fasciculation headache nor neck pain there was no history of trauma febrile illness polio exposure to toxin and heavy metal in the past there was no family history of similar complaint nor neuromuscular disease neurological examination လုပ်လိုက်တော့ thenar and hypothenar muscle wasting နဲ့ atrophy တွေကိုတွေ့ရပါတယ် fasciculation တော့မရှိပါဘူးဒီ second picture မှာပြထားတာကတော့ wasting of the FTI နဲ့ small muscle of the hands ရဲ့ wasting က mark wasting ကိုတွေ့ရတယ် right side မှာပို့ပြီးတော့များပါတယ်နောက်တစ်ခုကတော့ oblique amyotrophy of the forearm typically ပြထားပါတယ် wasting of the forearm with relative preservation of the brachioradialis muscle ဒါကို oblique amyotrophy of the forearm လို့ခေါ်ပါတယ်ဒါကြောင့်မလို့ဒီ case မှာ slowly progressive weakness and atrophy of the right hand and forearm without sensory symptom အဲ့တော့ကျမတို့ဘာ differential တွေစဉ်းစားပါတယ်လဲပေါ့အဲ့တော့ differential diagnosis စီ motor neuron disease ALS ဖြစ်နိုင်တယ်လို့ monomelic amyotrophy or Hirayama disease ကိုလည်းထည့်ပြီးစဉ်းစားပါတယ်ဒါကြောင့်မလို့ကျမတို့ investigation နဲ့ဆက်လုပ်တယ် nerve conduction study normal EMG မှာ active denervative နဲ့ chronic renervative changes တွေဟာ one region မှာပဲတွေ့ပါတယ် right upper limb မှာပဲ MRI ကို procedure လုပ်တယ် MRI ကို flashing extension position နှစ်ခုနဲ့ရိုက်တယ်ပထမပုံမှာတော့ posterior epidural space widen in the flashing sequence မှာတွေ့ရတယ် epidural flow void လေးတွေကိုလည်းမြားနဲ့ပြထားတာလေးတွေရှိပါတယ်ဒုတိယပုံကတော့ cervical cord atrophy ကိုပြထားတာပါဒီ MRI မှာ typical features of flow void နဲ့ subcord atrophy ဒီ typical features of Hirayama disease ပဲဖြစ်ပါတယ်။ Hirayama disease ဆိုတာဘာလဲဆိုတော့ monomelic amyotrophy လို့လည်းခေါ်တယ် progressive amyotrophy လို့လည်းခေါ်တယ် Sobu disease လို့လည်းခေါ်ပါတယ်။ It is a rare benign disorder. It is a focal lower motor neuron type of disease. Mainly young male in the second and third decade of age are mostly affected. Mostly seen in the Asian countries. And the MRI of cervical spine in flashing will reveal the cardinal features of Hirayama disease. Early diagnosis is necessary because the use of simple cervical collar prevent neck flashing, so it can prevent disease progression. This slide shows the difference between Hirayama disease and motor neuron disease. Hirayama disease is တက်ငယ်တဲ့သူတွေမှာဖြစ်တယ် wasting က typical oblique amyotrophy ရှိတယ် disease progression သည် slowly ပဲသွားပါတယ်အချိန်တစ်ခုရောက်လို့ရှိရင်သူ့ရဲ့ disease ကဆက်ပြီး progress မဖြစ်တော့ဘဲနဲ့ arrest ရပါတယ် EMG changes တွေကတော့ခွဲလို့မရဘူး MRI မှာ typical features တွေ့ရတယ် usually တော့ Hirayama disease စီ motor neuron နဲ့ရှင် good prognosis ဖြစ်ပါတယ် so my last case the case 4 37-year-old man present with acute onset of throbbing pain in the right scapula and lateral shoulder area extending to the right side of the neck. The pain is very severe and intolerable, wasn't in the supine position, preventing sleep. Pain was not relieved by NSAID and significantly impact daily life and work. There is no fever, headache, tingling and numbness of the limbs, no problem with walking, speech and swallowing. 3 weeks after the onset, the patient experienced a decrease in strength of the right shoulder joint abduction and external rotation. At 8 weeks, the pain significantly reduced, not affecting sleep or work, but still experienced right upper limb weakness. So, neurological examination show marked atrophy at the right scapular region. Right shoulder abduction and external rotation are 4/5. No abnormalities found in the other neurological examination. And sensory examination also normal, no time wasting, no fasciculation. So the summary of the case 4 is acute onset severe pain, right scapula, followed by wasting and weakness of the right upper arm. So these differentials are considered. One is suprascapular neuropathy, second is cervical radiculopathy, the third is MND or ALS, and the last is neuralgic amyotrophy. That's why we proceed to the investigation. MRI cervical spine and brachial plexus, my protrusion at the C4-5 and C5-6, nerve conduction study normal. EMG show chronic radiculopathy changes at the C5. So according to this typical presentation of very severe pain and weakness without features of other motor neuron disease predicative sign. This patient has neuralgic amyotrophy, so-called idiopathic brachial plexus and percentage Turner syndrome. It is an idiopathic inflammatory condition affecting the brachial plexus, characterized by sudden onset of acute severe pain in one or both shoulders and rapid onset of weakness in the muscle of shoulder girdle and upper arms. Usually monophasic and self-limiting with good recovery. So this is my last slide. So the key point in my presentation is that motor neuron disease is a devastating progressive neurodegenerative disease which is irreversible. And we consider the diagnosis when faced with progressive painless weakness in patients over the age of 50 years. Weakness and wasted muscle with retained reflexes is highly suggestive of MND until proof otherwise. Cognitive impairment is a common feature of ALS. There is no definite test to confirm MND, but investigation may aid in diagnosis and assist in the exclusion of other conditions. Lower motor neuron predominant monomelic clinical subtypes present the greatest diagnostic challenge, but are frequently more slowly progressive. The prompt referral of such patients to specialist neurological services for assessment is thus important. With this, I want to conclude and thank you for kind attention.
Zifam, caring for well-being.